Good morning, everyone. I am Dr. Syed Farhan, Junior Resident from Basaveshwara Medical College and Hospital, Chitradurga, Karnataka. I am presenting a paper on the case series of brain malignancies. The aims and objectives is to assess the imaging findings of spectrum of brain malignancies. Research methodology: the cases were collected retrospectively from the Department of Radiodiagnosis, Basaveshwara Medical College and Hospital. Cases were diagnosed to have various brain tumors. Contrast-enhanced MRI was performed for these patients. Case 1, the chondrosarcoma of brain. A 50-year-old female patient presented with progressive headache and diplopia, a well-defined heterogeneously appearing mass, hyperintense on T2 weighted and flare, and hypointense on T1 weighted imaging, approximately 35 cross 24 cross 30 mm, with multiple foci of blooming, no evidence of diffusion restriction, epicentered in the left petroclival region, with its extension anteriorly up to the orbital apex, invading the cavernous sinus and abutting the left optic nerve. Laterally displaces the petrous and the cavernous part of left ICA and focally encasing the ICA greater than 180 degrees with buckling of medial temporal lobe. Posteriorly into the prepontine cistern and buckling of the left hemipons. Inferiorly extending up to the C1 vertebral level, just lateral to the left longus colli muscle. The pituitary gland appears normal. Posteromedially, the mass is seen abutting and displacing the pituitary gland to the right. The cranial nerves: cisternal segment of left trigeminal nerve is stretched and the mass is seen invading the Meckel's cave. Abducens nerve is not visualized. There is invasion of duralis canal on the left. 7th and 8th nerve roots are also stretched, but seen in the posterior aspect of the mass. The lesion shows subtle heterogeneous enhancement on post-contrast study. Screening CT shows destruction of the apex of the petrous bone and clivus on the left is noted. Thinning of body of lateral wall of sphenoid sinus involving carotid canal and greater wing of sphenoid. In case 2, meningioma, a 37-year-old female presents with new onset of seizures. We have a rounded extraaxial iso-intense mass on T1 weighted imaging, iso to hypointense on T2, and approximately measuring 49 cross 50 cross 41 mm. There is evidence of blooming on SWI noted arising from the dura of right anterior cranial fossa. There is an enhancing dural tail that is seen between the lesion and the adjacent brain parenchyma, and the buckling of the adjacent gray matter is noted. There is no evidence of surrounding edema. The mass effect is causing buckling of the rostrum and the genu of corpus callosum with a mass midline shift of 5 mm towards the left. The lesion shows post-contrast heterogeneous enhancement. Coming to case 3, the vestibular schwannoma. A 45-year-old female presents with unilateral sensorineural hearing loss and tinnitus. There is a T1 weighted, iso-intense, T2 weighted, and flare hyperintense lesion measuring 43 cross 30.2 cross 26.2 mm, noted in the left cerebellopontine angle, extending into the internal auditory canal. There are few foci of blooming noted on SWI with no evidence of diffusion restriction. This lesion is seen causing mass effect over the left lateral aspect of the brainstem, left cerebellum, the fourth ventricle, and the fifth and sixth cranial nerve. The lesion shows a homogeneous enhancement on post-contrast imaging. Case 4, we have a high-grade glioma. A 70-year-old male presents with rapidly progressive cognitive decline and a right-sided weakness. We see a well-defined cystic mass appearing heterogeneously hyperintense on T2 and flare, and heterogeneously hypointense on T1 weighted imaging, approximately measuring 51 cross 36 cross 37 mm, seen in the left temporal lobe. There is significant surrounding vasogenic edema with mass effect over adjacent neuroparenchyma causing effacement of sulcal spaces, ipsilateral lateral ventricle, and a midline shift of 1.2 centimeters towards the right. A focus of diffusion restriction is seen within the mass, few foci of blooming seen on SWI. On post-contrast study, there is heterogeneous enhancement of the solid component and peripheral enhancement of the cystic component. There is left uncal herniation seen with mass effect on the midbrain. Coming to case 5, pituitary macroadenoma. A 19-year-old female presents with bitemporal hemianopia and amenorrhea galactorrhea syndrome. We have a well-defined lobulated cellular lesion extending into the supracellular region, measuring approximately 23 cross 22 cross 30 mm, appearing iso-intense on T1 weighted imaging, on iso-intense on T2 weighted imaging, and heterogeneously hyperintense on flare. There are T1 weighted hyperintense and areas showing blooming on SWI noted within the lesion, which are suggestive of areas of hemorrhage. The post-contrast image shows a heterogeneous enhancement. Mass effect is noted causing enlargement of the cella, compression of the optic chiasma more on the right than the left, seen compression on the bilateral sphenoid sinuses. On its extension, right lateral is seen extending into the right cavernous sinus and encasing the right carotid artery for a NOS grade of 4. Superiorly, it is seen extending into the suprasellar cistern, anteriorly towards the sphenoid sinus, and on the left side, the lesion is seen extending into the up to the medial wall of the left internal carotid artery for a NOS grade of 1. Rest of the sphenoid sinus and the clivus bone appear normal. Coming discussion, chondrosarcoma is a rare malignant tumor of cartilaginous origin, typically occurring in the skull base. The imaging hallmark is a chondrine matrix producing rings and arcs on CT. On MR, it is T2 hyperintense due to the high water content in hyaline cartilage and shows moderate to marked heterogeneous enhancement. It must be differentiated from a chordoma, which is typically midline and shows more homogeneous enhancement. Anangiomas are the most common extraaxial brain tumors. Classically, MRI features a dural-based, well-circumscribed mass that is iso-intense to gray matter on T1, hyper-intense on T2, and shows intense homogeneous enhancement with a dural tail. We typically have a relatively high relative cerebral blood volume and perfusion. Vestibular schwannomas present as an enhancing mass in the cerebellopontine angle internal artery canal complex, often with cystic changes. They are characteristically T2 hyperintense. Bilateral lesions are diagnostic for neurofibromatosis type 2. A high-grade glioma is characterized by the aggressive features on imaging, irregular ring enhancement surrounding a central necrosis. There is significant perilesional edema, infiltrative growth patterns, including cross-commissural spread. Advanced techniques like DWI, MR fusion, and MR spectroscopy are crucial for diagnosis and grading. Pituitary macroadenomas are benign tumors which are greater than 1 centimeter in size. Their imaging diagnosis relies on identifying a cellular or supracellular mass with characteristic figure of 8 shape. Relatively less enhancement than the normal pituitary and displacement of the pituitary stalk and optic chiasm. Assessing cavernous sinus invasion and involvement of the internal carotid artery is critical for surgical planning. In conclusion, as described above, there are various types of brain malignancies with distinct imaging appearances. An understanding of the radiological features of different brain tumor subtypes is essential for an accurate diagnosis, surgical planning, and guiding further management. Features suggesting an aggressive or malignant behavior include irregular margins, heterogeneous enhancement with central necrosis, significant perilesional edema, restricted diffusion, elevated perfusion, and infiltrative growth patterns. The differentiation between these entities is crucial to provide appropriate prognostic information and guide clinicians towards optimal therapeutic strategies. These are my references. Thank you.